Today I'm joined by Marc Miller. Marc is a seasoned healthcare strategist with deep experience in PHI and healthcare systems advisory. He spent over a decade at Medibank, where he led strategy, innovation and transformation efforts, shaping Australia's biggest and most innovative private health insurer. Now as MD of Healthcare Systems Advisory, Marc provides strategic guidance to payers, providers and investors across global healthcare markets. With his unique perspective on innovation, strategy, insurer-provider dynamics and the future of healthcare, I'm very excited to get into today's discussion. Welcome, Marc.
Good to be with you.
Great to have you here. Thanks for joining us. We're going to go straight into the deep end. I know
Sure.
You've got a lot of experience in local and global markets around payers and providers. In Australia, we've seen some pretty major public battles playing out between private hospitals and private health insurers over the past 6 to 9 months. I'm keen to, understand that a little bit and also just sort of capture your opinions about what are some of the drivers and things that have sort of contributed to the position we're in and some of these battles playing out, and how do you see things going from here?
Well, I'd probably start off by saying this is nothing new. I've still got plenty of scars from back in 10 years ago or even more, when we had some interesting contractual negotiations with some of the large hospital groups and trying to implement value-based elements to contracts and these kind of things. There's plenty of history there, so it's not necessarily a new thing. I do think, however, that the circumstances in which the private hospital operators find themselves has probably contributed significantly to the current situation and the acrimony between both the insurers and the hospital groups predominantly. I think it's probably good to look at where the private hospitals are today. If you look at the lead up to the beginning of COVID, in that decade leading up there, the private hospitals expanded their footprint probably more so than any time in history, both in the acute space and the subacute space. And so during that time, it was, the belief that sort of growth in volume and demand would go on forever. And I think you have to bear in mind that the majority of growth from a revenue perspective for hospitals was always in volume rather than in price or shift in mix. So there's been obviously those dynamics leading up to COVID, that massive expansion of acute hospital space. But since COVID, obviously, and during COVID, the kind of demand that was always forecast hasn't materialized. Obviously, there was a lot of impact of COVID, particularly during that 2 to 3 year period. But even since, the rebound in demand hasn't been as expected, which has left the hospitals with greater occupancy than they were anticipating. Concurrently, obviously, a lot of their costs have gone up through COVID, both labour, consumables, rent, power, and other things. And they've also concurrently seen a mix shift from overnight to day. So whilst the overnight portfolio hasn't been growing, the day portfolio has, but that's at a lower revenue base per procedure than the overnight procedures. So you've had this sort of perfect storm for hospitals, which has really impacted their margins, to the point where the only solution I think that they see in terms of remedying their current position is to get more money out of the insurers, because they represent 80-85% of the revenue base. And it's the quickest and easiest means to address the bottom line impacts they've got, where, gross margins, EBITDA margins have declined significantly since the heights pre-COVID. So I think in that context, they're obviously looking to the insurers to make them whole, or at least bring them back towards where they were historically. And the insurers concurrently are faced with a dilemma that we know the 2 main reasons why people drop out or downgrade their private health insurance is 1, the cost of premiums, and 2, out-of-pocket charges when they do use their private health insurance. So, if you look at that period pre-COVID, the actual number of people with hospital insurance in Australia was actually declining, not just at a population penetration level, but in absolute terms. And similarly, there was huge rates of downgrading. I mean, at the point, I think in 2019, I think about 11 of the 30-something private health insurers were making underwriting loss. So
yeah, I do recall, I think it was the Grattan Institute at the time, they labelled it a death spiral. Private health insurance was heading into a death spiral.
Yeah, I mean, private health insurance has always competed with the public system. And in that lead up to COVID, the public system had built a lot of shiny new public hospitals with single rooms and en suites, and the value proposition for private health insurance was relatively diminishing. But obviously, during and since COVID, waiting lists blown out, access problems, all the things we know about in the public system has actually pushed more people back into private health insurance. Interesting, a lot of the growth has been in the younger population, which doesn't use hospital all that frequently. So even though the number of people insured has grown quite markedly during and since COVID, it hasn't necessarily translated into significantly higher demand for hospital. So the insurers don't want to go back to the scenario of people dropping out and downgrading private health insurance. It's not good for the hospitals or doctors either. And there is an affordability crisis, as you may have heard, in the rest of the economy. But at the same time, the hospitals, because they've been ploughing down the same path and have had the same strategy for decades, they have no alternative mechanism for actually remedying the financial position they find themselves in. So we're at an impasse, I think, and the way a lot of the insurers have been looking to try and solve the problem is through ex gratia or temporary or one-off type payments, which then means that the additional cost is not baked into the underlying fees that are paid to hospitals. Hospitals are obviously, reluctant, it's not their preferred course of action, and the way that they're trying to address this is to try and pressure government in an election year to compel the private health insurers to things like a minimum payout ratio, with sort of numbers being plucked out of the air as what would be deemed an acceptable minimum payout ratio. There's been talk previously of things like a national efficient price for private hospitals, but that I think has divided private hospitals, because some of the groups which currently earn a lot more than others because of their market power aren't particularly keen on a national efficient price, because they may well go backwards in that negotiation. So I think they've tried to settle on a model of compelling or getting government to compel a minimum payout ratio, and they've picked 88 cents in the dollar. The Americans have an 85-cent minimum payout ratio before you start having to pay back money to members. To be frank, I think the minister will probably be trying to kick the can down the road to a post-election and minimise the noise, because
it may not be his decision then.
one thing the politicians don't like is noise. One of the things they particularly don't like in an election year is noise in healthcare. So that's sort of my assessment as to where things are and how we got here.
Yeah, wonderful. Thank you. It's a great summary. Then maybe you sort of touched on some other markets there. I think it's very easy living in Australia to think we have the perfect healthcare system. I've certainly shared some perspectives recently and seen yourself and others share perspectives that perhaps it's not as perfect as we naively think it is. I'm keen to get an understanding from you what elements of other markets, North America, the UK, Europe, given your experience, do you think there are elements that Australia could take that could be useful to improving our healthcare system?
I mean, I certainly think there is. I mean, I think sort of touching back on the previous question as to how we got to the acrimony between insurers and hospitals, I think both the public and the private hospital system here has been have been particular laggards in embracing the new world. If you look at the infrastructure that we have today in Australia, it was built for the last millennium. Large acute hospitals, lots of beds, etc., etc. And to be frank, given the, if you'd have had your head above the parapet 20 years ago, which is when a lot of these hospitals, both public and private, should have been looking, there's been an enormous transition, say, in the US market from inpatient surgery to outpatient surgery, the massive growth in ambulatory surgery centers. And these are different to the day hospital sector that we have in Australia. These are effectively 24-hour hospitals which are doing a lot of what today in Australia are overnight procedures in a 24-hour environment. Much lower cost, much more efficient, routine surgery, better outcomes, lower hospital-acquired complications, falls, all these kind of things. And Australia has been very slow to embrace that element of hospital care. Simultaneously, I think the model of general practice in Australia is, once again, last millennium. It's a reactive, passive model of general practice. You rock up when you're sick. You never hear or see from the GP or the practice in between until you rock up again when you're sick again. And so that is a really outdated model of care. The difficulty we have in Australia is that general practice is effectively a cottage industry, even in the large groups, some of which we invested in Medibank. It's still an amalgam of small businesses with a little bit of a corporate overlay. And the kind of sophistication that you need in terms of data analytics to be able to do predictive, proactive healthcare, and also the sort of the B2C marketing mentality that you need to not just identify gaps in care and people who are at risk of hospitalization, but to be able to recall them back into practice or go and see them in the home, whichever the channel you may choose, online, virtually. You actually need some smarts and sophistication in how you approach that and how you engage the end customer. General practice in Australia, even at the corporate level, the model has been about getting bums on seats. It's about keeping the GPs happy. It's a B to B to C model. If we get enough GPs who are, sit behind a desk long enough, we'll fill it up with patients and we'll make some money. And that's sort of been the mantra, but nobody's ever considered, really implementing some of the much more sophisticated models of either primary care, and as I said, hospital care particularly, whether it's just the infrastructure we have today or the move towards virtual hospital and hospital in the home. We've been really slow to embrace those elements of care delivery.
Yeah.
And I've thought quite long and hard about why that is. And it probably talks to some of your later questions around innovation, is that if you look at the innovation which happens in sort of life sciences space, biotech, med tech, pharma, all these, you've got enormous amount of innovation that goes on. But these organizations tend to be led by clinicians who have got that sort of scientific, methodology mindset, constant questioning, constantly, looking at
experimentation,
big problems and how do we solve them. In the healthcare services world, with some exceptions, a lot of the people delivering or managing or leading these organizations are non-clinicians. They're, corporate types like me. And they're effectively managers, people that turn the handle and grind out, improve performance year after year. And nothing wrong with that. But they don't have that DNA. They don't have that innovation mindset for the most part. And they've been content to stick with the same old, even though if you actually had foresight and you were looking at what was going on elsewhere in the world, the kind of situation that hospitals and primary care are in today was entirely predictable and would lead to, fundamentally different models of care delivery.
Yeah, that's a really interesting point, and we have discussed this briefly before, and I think this sort of links some of these things together. If you think about, there's been a push to day surgery, so shorter stays in hospitals, which are essentially healthcare real estate businesses. So low occupancy, or shorter occupancy means less revenue. You've got the emergence of healthcare at home and digital health and telehealth. Obviously, insurers have a financial interest in people spending less time in hospital, because that's their biggest, or their biggest cost base. Is, if you kind of step back and look at that, like, why haven't hospitals really invested in this innovation? And is it, I mean, you said they're largely led by corporate, or you've got returns, sometimes you've got private equity involved. They're real estate businesses, they're not necessarily health tech businesses. I'm curious to unpack that a little bit.
I mean, to be frank, they up until COVID, they hadn't had to, because you could basically do very little and churn out 6-7% growth, 4% volume growth, 3% price and mix shift growth, and you didn't really have to do much. So I think there's an element of laziness. I mean, when I compare some of the most sophisticated operators, say in the US, not that the US is a beacon of healthcare cost containment or quality necessarily, but the best of the best in America are better than anywhere else, pretty much globally. And if you look at the level of investment that's gone into things like data analytics, and really understanding care pathways and understanding how you actually broaden your offering beyond the hospital walls to be able to deliver value across the chain, the American operators are light years ahead. I mean, I look at an HCA, for example, and they are light years ahead. And I don't know that I've come across any of the major hospital operators, for example, in Australia, that would be within a decade of an HCA, in terms of their sophistication and how they operate. And as I said, they didn't have to for a long time, because they are able to eke out decent margins, strong growth, without having to do too much. But I still think the absence of clinical senior leadership. When I say that, I mean, obviously all of the groups have chief medical officers and the like, but very few of these groups are ever run by people from a medical or clinical background. If you go to America, there is a much stronger tradition of doctors and scientists and others running healthcare delivery organizations. I mean, you can go to Harvard and there's a particular MBA for doctors at Harvard, right? You just don't see that same kind of crossover. And so, as I said, it's been these operations have been run by managers, people without the innovation mindset necessarily, and I think that's really been to the detriment of the Australian healthcare services delivery market. Saying that, it's not universal, but it is the sort of the dominant feature in terms of leadership and management within these organizations.
Yeah, it's a really good insight. And I think that with the combination of, like you said, when sort of pre-COVID, there was no real immediate incentive to innovate or do anything differently, because you could get your 6 or 7% growth, you could get a X% yield, or occupancy.
And to be clear, the insurers have been no great shining light in terms of innovation either. I mean, for decades, the insurers did very little apart from being a dumb payer of bills. And I spent a decade at Medibank, 2012 to 2022, and I was agitating from sort of day one that we needed to do something fairly fundamentally differently. If you fast forwarded where benefit outlay growth was going and affordability was going, we needed to do something fundamentally different to be able to ensure that private health insurance remained affordable for the public. And it probably took me at least half that time at Medibank to, of agitation to actually, get the backing to do something sort of fairly substantially different. Not that the prior CEO, the prior CEO was actually fairly innovative, to be honest. But in terms of getting the hard investment dollars to actually move into things like ASC investment, into primary care, into virtual hospital and hospital in the home, it really took me at least half the time at Medibank before the organisation was sufficiently convinced to actually push forward with that. So
yeah,
I want to be clear. It's not that I put all the blame at the door of the hospitals. There's been plenty of blame to go around, and I think one of the things that the private health insurers didn't do enough of for a long time was to actually using their funding levers to promote day hospitals and ambulatory surgical centres, and I probably think to this day they still don't.
Yeah. So maybe let's turn to that. We have seen, particularly since COVID, a lot of the insurers in Australia in particular focus more on playing a more active role in the healthcare system and sort of expansion of role and services across the value chain. It's interesting when you look in cycles and kind of what drives innovation. And I'm just sort of unpacking some of the things you've said around, sort of if you've got tailwinds and things are good, there's less motivation to
Sure.
change, right? To do anything different. If you've got the right leadership in place, that can certainly have a substantial impact on sort of accelerating your innovation capability. But also having mindsets and people in-house who are willing to sort of just push the agenda and go, no, this is the future. We really need to make sure, and persistence, I think, is key there as well. But so is that sort of change in insurer mindset? If you look at any of the Australian major insurers, their purposes are pretty much the same, or their missions, pretty much you change a few words here or there. But right, it's all this about moving from a payer to a health partner. Medibank was certainly at the forefront of that, and I would, I talk about this. I produced an innovation report on the industry last year, and from what I can understand, Medibank are just years ahead of competitors.
Well, I would say, just from a pure innovation perspective, I don't think Medibank is probably any more innovative than any of the other major insurers, or even some of the smaller ones. And I don't say that to be critical of Medibank or even former colleagues there. I just think Medibank's had a different focus. In private health insurance, you've really got four levers to affect your financial profile. You've got member attraction, member retention, you've got your benefit outlays, and then you've got all of your administrative costs. And in the scheme of things, your admin costs are pretty small relative to your benefit outlays, right? So if you're actually going to make a fundamental difference in private health insurance, it's either member attraction, retention, or effectively your claims line. Now, the other insurers, if you look at their sort of push into healthcare or wellness or whatever you want to call it, they're much more focused, I think, on member attraction and retention. And I think the difference with Medibank is that from day one, certainly when I joined, we were focused on what do you do about avoidable hospitalization? Or what do you do about the cost of hospital care, which may be unnecessarily high relative to modern methods of delivering care? So, I remember sort of in my first few months there, one of the first things I did, I would have a look at these reports about where Medibank spent its money, and it would be, reports about how much we spend on orthopedics or cardiology or whatever. And I actually asked a fairly, and this will, we can circle back on this from an innovation perspective. I actually asked the question as to who do we spend the money on, which frighteningly was a question that had never been asked previously. And so, you know, the curiosity to go through the data and to look at the data and slice it and dice it in different ways revealed that about 2.5% of the membership base recurrently, same people every year, accounted for about a third of claims costs every year.
Wow.
So, and this is the same in the public system. And so the question then is, what do you do about it? Or can you do anything about it? Or are these people just so sick, they're multi-morbid, whatever, they're just so sick, there's nothing you can do about it. So we actually went and visited some of these people to see what was going on in their world. That meant that they went to hospital 4 times a year. They had 4+ chronic conditions on average. They saw 7 different doctors on average. And I think some frightening statistic, like they were on an average of 20 different medications, something, you know, ludicrous, right?
Wow.
So we went to visit them, and I still remember to this day, there was a woman who had her medication list. I asked to see it, and it'd obviously been in the bin because it'd been crumpled up and then sort of flattened out afterwards. But she used to take it to the GP and say, prescribe me this. And so, you know, we spent a fair bit of time trying to understand why these people, and these people weren't in the last 12 to 24 months of life. They've been doing this for decades. They were just in their entire life, and their entire life of their family and so forth was spent coordinating their care, shuttling them between different doctors and hospitals. It was tragic. And so one of the first things we did to say, is there actually a service or program? Can we put a SWAT team together in partnership with the GP to, you know, to supplement the GP to actually keep these people out of hospital? Because they didn't really enjoy going to hospital very much, believe it or not. And they didn't enjoy being sick. So, you know, one of the first programs we put together was a program called CarePoint, which is how do you keep complex multi-morbid patients well in the community? But, you know, this was a function of looking at, you know, the data, looking at, you know, things in a different way. So right from the beginning, Medibank was focused on, are there things that you can do to actually reduce avoidable hospitalization or to have right setting, as opposed to really expensive long overnight hospital stays, which in the modern era with minimally invasive surgery are not really necessary. Do medical patients need to be in hospital, or can they be cared for at home? And so, you know, that I think is the fundamental difference. And once you go down that path, I would have spent years talking to hospital groups, to CEOs and execs of large hospital groups, trying to persuade them to say, listen, it's time that you actually stop building large acute hospitals and start putting in place the right infrastructure for the modern world. And to be honest, I didn't get a great deal of I didn't get much reception in terms of that discussion. And so you were left then with the conclusion, well, if nobody's going to innovate around the hospital model, if nobody's going to innovate around the primary care model, let's do it ourselves in partnership with doctors, and let's see if we can catalyze change in the market that way. And it's really no more complex than that. So where others have been sort of piling down the path of things like, you know, digital access and dental and optical and these kind of things, none of that really shifts the needle on, you know, the way that healthcare is delivered. It will attract and retain members because you can do some interesting things between your insurance offering and your dental offering or your optical offering, but it's not going to shift the needle on, you know, on fundamentally changing the way that healthcare is delivered. So it's not that Medibank doesn't do plenty of innovative stuff around member attraction and retention, or, you know, it does. But what I don't think the others have done is really plowed down the path of trying to change the dynamic of the way that healthcare is actually delivered to get better outcomes for consumers, to get a better experience for consumers, and concurrently greater affordability for consumers. I mean, people that have, things like joint arthroplasty done same day or one night stay and have nursing and allied health going into their home that day or next day, their experience of healthcare and their feedback is far better than it is sitting in a hospital for 5 days, being woken up 3 times a night, and complaining about the food and the parking. So, it's essentially a different focus, but it was born, I think, really of trying to get a much broader global picture around where healthcare is going, to remove the blinkers, and then to say, what is it that we can either implement or adapt in Australia that would actually catalyze that change for the better for consumers, but also for clinicians working in the system as well.
Yeah, that's a really good insight. Thank you. And I guess on production of this innovation report, there's just been a lot of interest of people going, well, what's the secret sauce at Medibank? What are they doing that we're not doing, or what are they doing that others aren't? And I've never been able to fully understand that. And I think you've provided some really good insight there. Is just around the sort of the starting point, but also just there's some really, I think, some strong themes there that you've touched on that are just, I would say, some really good lessons and fundamentals for innovation in general, which is around using analytics and data for decision making, right? You said really early on, you said, okay, well, who are we spending the money on? And you discovered that it was, I can't remember the numbers, but it was like 2.5% of members are causing this percent of claims or whatever it might have been.
Yeah.
And then you went and you actually you did some primary research. You went and spoke with the consumers. You took that customer first or that member first approach. And that's often overlooked. And those of us who work in innovation know that that's a fundamental and really foundational research method, but it's often overlooked if you've got, particularly when you do have people who don't necessarily have that mindset or that experience to understand the real value of actually going and talking to your consumers that you're trying to serve, understand their problems intimately, so that you can actually solve it in a creative and in a way that is not only pleasing them, but it's giving them better experience, but it's also helping achieve your commercial objectives.
Yeah, I mean, sort of the starting point though is you need senior leadership that has that curiosity, people that aren't just grinding the wheel to eke out margin improvements year after year, and to the extent whether that is something which is hardwired into your DNA, or whether it's something that's socialized before the age of 7 or whatever the age is, I don't know. But it's very hard for organizations which don't have that DNA within their actual individual senior leaders to actually develop an innovation culture and mindset. And I lived in China for 18 years and in Singapore for a couple of years, and it was always really interesting because the phenomenal success story that Singapore is. When I was there, Lee Kuan Yew was sort of in his last years of leadership in Singapore, and he would always bemoan the lack of entrepreneurial activity and innovation within Singapore. And I thought, for such a bright guy, he's got such a blind spot in that it's almost, in his mind, you can compartmentalize free thinking and entrepreneurship and innovation. In the political life, everyone has to be compliant and unquestioning, but they're going to walk into the office and remarkably, they're going to be curious, questioning, and everything else in their sort of business life. And it's impossible to compartmentalize. And essentially, unless, as I said, you have people at the senior level with that in their DNA, you're really going to be pushing it uphill in terms of generating that sort of kind of culture within the organization. Now, I look at both my sons are at school here in England, and I was talking to my son the other day, and he goes to a good school, and the school constantly pushes them around innovation, constantly. He was doing a project around generation of power generation using antimatter. This is a physics project, right? Which by the time he'd got 30 seconds into it, I was already lost. But constantly it's being pushed and reinforced, to look at significant problems, look at them in different ways, understand what the problem is, understand the range of solutions, and start to try and devise solutions to some of these wicked problems. And for him, it's a he won't. There's almost nothing he won't look. I mean, he'll look at the toilet and he'll say, "Why does the toilet hasn't changed in 100 years? There must be a better way of doing it, right?"
Yeah.
And so, as I said, it's almost ingrained, whether it's hardwired or whether it's been socialized into him. Don't ask me; it's beyond my comprehension. But I think there's too few people in healthcare services, and not just in Australia, but UK is similar, that have that kind of thinking and mindset. They're much more focused on, as I said, turning the handle a little bit better this year than we did last.
Yeah, that's I guess to sort of bring that down to curiosity is a word to talk about a lot with guests on this pod as one of those kind of foundational pillars of innovation, and having that at the top, like you said, in senior parts of the organization makes it much easier to permeate through the culture, right? And I think it's understated and difficult to quantify, certainly in immediate year, if you know what I mean. Like you can't, sort of month by month, 6 month by 6 month, year by year, reporting by reporting. It's hard to kind of articulate the value of that. It's not until you look back and you go, wow, having that in place at that time, look at the difference that has made to the organization.
But it's a scientific mindset methodology. I mean, one of the things, if you look back at Medibank, just from a financial perspective, pre-COVID, in a few years pre-COVID, there was quite a significant jump in profitability within a year. And some of that was, some of the things that Medibank had done, like, for example, having a dual brand strategy, one brand focused on, the value conscious consumer, and another sort of the Medibank brand focused on the sort of people who are looking for quality and so forth. I mean, but one of the sort of things that actually shifted the needle for a fair bit from a profitability perspective was something that got very limited airplay, which is what we call payment integrity, which for any of the hospital operators out there or dental operators, and they'll be cursing me as I say this, but I sort of, as I said, looking internationally, one of the things that struck me was the staggering amount of money and focus that's spent in, say, the US market on fraud, abuse, and error in healthcare, and they're still sitting at 2 or 3% fraud, abuse, and error. In Australia, it didn't even rate a mention. And so we took the hypothesis and actually got some external partners who are formidable in this process to actually look at the data to try and understand whether we had significant problems in fraud, abuse, and error in Australia. And I'd like to say there wasn't, but it was staggering. And the level of, I mean, just the comedic value of some of the things. I remember I had a dentist in front of me in my office in Phillip Street, and I said to him, he was an old guy, and he had his wife there translating, even though he spoke, I think, fairly good English. And I said to him, listen, I'm not a dentist, but I find it difficult to understand how you did 140 5-sided fillings on New Year's Eve, which is when all of the when all of your extras
of course,
expire,
the benefits,
right? The benefits expire. And I said, how long does it take to do a 5-sided filling? And I think he said, I don't know, 10 or 15 minutes, right? I said, I'm not a mathematician, but it doesn't really add up, right? And so, but it was literally a catalogue, wherever we looked across the portfolio, and eliminating or reducing this it was a complex exercise. I mean, identifying it was relatively easy. Not easy, but relatively easy. Actually implementing the change was hard. So, but it was, looking broadly, forming hypothesis, testing the hypothesis. It's that kind of mindset. You sit in an organization, whether it be a Medibank or a hospital group or any corporate in Australia, how often are the people at the coalface, the people working in the trenches, how often are they asked, is there a better, more efficient, more efficacious way of doing your job? Never.
Yeah.
And if that's not in your DNA as an organization, it's very hard to acquire.
You just got me thinking about something just slightly off topic there, talking about some of that fraudulent behavior. I wonder if that's in part symptom of the business model of certainly the healthcare system, where the user of the service is not necessarily the payer of the service. So that creates this not permission, but this loophole potentially where it's more difficult to trace or difficult to prove, because the person or the payer of the service is not necessarily the user of the service.
It's actually quite easy to track in Australia, because 90+% of claims in the private system in Australia are generated by providers. You don't have tens of millions of individual claims, which are much harder to spot for fraud. So all you're looking for is pattern recognition. You're looking at, how has this provider's claiming pattern changed over time? How does it compare to their peers? How does it compare to the rules, so forth and so on? So in Australia, it's actually quite easy to find. I mean, I don't want to give the impression that it's rampant, no. But if you think that 4 or 5% of spend before we started was probably, whether it was creative coding, whether it was outright fraud. I remember getting a letter once from an angry member in Queensland, and it said, you can edit this out if you want, but the letter said, or the email said, it started off, "You bastard," was the opening line. It said, "You've de-recognized the best dentists in Queensland. My dentist does 4 patients at the same time in 4 different chairs, and he's a wizard, and you've de-recognized him." And I'm thinking to myself, it was probably a good job that we de-recognized him if he's got 4 patients on the go in the same clinical room. But
a good decision.
But I don't want to give the impression it's rampant. Most providers, I mean, the level of sort of nefarious behavior is no different in healthcare than it is in any other. When I was talking to one of the CTP insurers in New South Wales at a conference once, and he said 25% of claims for CTP in New South Wales were fraudulent.
Wow!
So I actually felt better about it myself after 5%.
Doesn't sound so bad, right?
But sort of coming back to innovation, it's really the mindset, the mentality. How do you think about things? How do you think about? Do you constantly question, why do we do it this way? Why is it this way? Are there better, more efficient, more efficacious ways of doing it? And if you don't have that mindset, as I said, it's really hard to acquire.
Yeah, absolutely. I'll shift gears slightly and maybe look to the future, again, with that particular focus on the Australian private healthcare market. If you had to bet on one major shift or sort of one major theme change over the sort of coming 5 or 10 years in the Australian landscape, and that could be I'll say in the private healthcare landscape, so it could be in how healthcare is delivered, how it's paid for, who's playing whatever roles, whatever it may be. What are you sort of seeing as the major theme or themes playing out?
I don't know if I make a bet on it, but if I could sort of wave a wand on it, I'd say vertical integration, particularly amongst in the provider side of things. That assumes that there's been all the requisite investments in data analytics and everything else that's required to actually execute. But I actually think that, instead of sticking to your lane as a hospital operator or as a primary care operator, I actually think we'll start to see, or we should be seeing, vertical integration. So you can actually be responsible for the patient from end to end, from primary care all the way through, if they need hospital, and all the way through to, every other aspect of their care. That kind of wish or prediction will go down like a lead balloon amongst most of the provider community, because there's some belief of purity that there's conflict of interest being in general practice land as well as hospital land and so forth. But actually, if you're really going to do a phenomenal job of actually managing the health of the consumer or the patient, having all of those different levers to pull, where I think Kaiser Permanente is not one of the best providers of healthcare globally for no reason. It's because they've got the ability to manage patients from end to end. And I can still, even 12,000 kilometers away from Australia, I'm already hearing the ring of US style managed care from whichever peak body wants to pull it out of their proverbial. But it's not that. I mean, if you are with Kaiser, and they're a health insurer as well as a vertically integrated healthcare system, but effectively, Kaiser in their primary care business will be looking at your data on a daily basis, and they'll be saying, does David have any gaps in care? He's diabetic, but he hasn't had his eyes and feet checked in the last 2 years. Let's bring him in and get that done. Or, Mrs. Smith is 70 years old. She's had a low trauma fracture, wrist fracture, but she's never been tested for osteoporosis. So let's get her in. Let's get her a DEXA scan or whatever it is. Let's see if she's osteoporotic. Let's put in place some program, because we know that if we don't address this, Mrs. Smith is likely to have a hip fracture, which is terrible for her and her family. It's also terrible from a healthcare cost perspective as well. So if you are a member of Kaiser, or you're in the Kaiser healthcare system, there is this constant focus on data and prediction, proactive engagement, proactive recall, trying to minimize hospitalization. And if you do require hospitalization, can this occur in the most efficient and effective environment for it to be done? So, and maybe you don't need to be in a physical hospital at all. Maybe it's a medical issue and we can do it at home. Come and do chemotherapy, dialysis in your home, whatever it may be. So, I mean, I think the ability to deliver that kind of care, I think is, it will horrify, no doubt, a lot of the clinicians and peak bodies who are watching this podcast. But the outcomes, the experience for patients is superior, and the overall affordability for the healthcare system and sustainability is superior. And if you get it right.
Yeah, absolutely. And who do you think is most motivated to lead from an industry perspective? Not necessarily, it doesn't need to be individual players, but I mean, are the insurers the ones with the most motivation to play that vertically integrated role?
I mean, this is what the large hospital groups should have done decades ago, and now to do it, I don't think it's feasible because they don't have the capital. So to disrupt their own model without the capital, they're all leveraged to the hilt pretty much.
Well, especially if we see one of the major players move into private equity hands, the costs are not going to, they're not going to get an increase in capital. If anything, they're going to have capital stripped out of.
Well, but the way I see it is that why would you buy a large hospital group unless you were going to do something fundamentally different? Whether you're a health insurer, whether you're a hospital, whether you're a private equity fund or an infrastructure fund, whatever, why would you just go and repeat the sins of the past, and just believing that there's going to be untrammeled growth because of aging and chronic disease in hospital utilization forever? So I would suggest, if anyone who's thinking about buying into private hospital land is just going to think that they're going to do a better job of it than the current owners. I think they're delusional. But, you know, there's a lot of people in this industry who have got their head in the sand. I mean, it's not just private or an infrastructure fund that bought the number 2 operator, but, you know, there's a whole bunch of, you know, there was a real estate investor piled in behind, believing that, you know, this was a no-lose proposition, which was, you know, almost laughable in naivety. So, you know, you've got a lot of people willing to throw money at healthcare without really contemplating what should the model look like to make it sustainable. And even today, I mean, there's very few aspects of the way that care is delivered today which I think are really contemporary and fit for purpose. I mean, one of the things that sort of at the tail end of my time at Medibank was looking at a brand new model of psychiatric care. I mean, for decades, and still to this day, people get sent to a psych hospital for 3 weeks at a time, get gardening and art therapy, might see a doctor once in a while, get sent home. 50% of the patients return the same year. I mean, if that was in any other area of medicine, there'd be a royal commission. It's the results are that bad.
That's right.
Yet it's been going on for decades, and nobody has thought, surely there's a better way of delivering this kind of care, right? And Kelsey people don't want to go to private psych hospitals now, and doctors don't want to work in them. I mean, I've got a job or family. Do I want to spend 3 weeks in a low-rent motel? You know, it's beyond belief that, you know, none of these things have been looked at and seriously questioned and challenged historically. So we may still find people willing to throw money at the problem without doing anything fundamentally different. I hope not, but I fear it could be the case.
Yeah, I do as well. Well, Marc, we'll wrap it up there. Thank you very much for sharing all of your insights and perspectives today. It's been wonderfully insightful, as I'm sure our listeners and viewers will get a lot out of it. So really appreciate your time, and thank you very much.
No problem. Take care.